Hi, I'm Dr. Stephen Allison. Welcome back to our videos on ophthalmology made easy. Today we're going to discuss the massive topic of diabetes and the eye. Absolute epidemic in this world because diabetes is a massive problem because there's just sugar everywhere. There's sugar hidden in all our foods, and we tend to consume too much sugars. So diabetes is really one of the big epidemics, the silent epidemics that we need to understand and we need to manage better. The problem with diabetes is it's very difficult to remember all the stages of diabetic retinopathy. To remember all the stages of it is really very difficult. So what you need to do is you need to have the pathogenesis in your head, like all diseases. Pathogenesis is everything. If you understand the progression of a disease, then etiology becomes easy, complications become easy, treatment becomes easy, and there are no surprises along the way. Now, to make it easy to remember, there are basically two big factors that are happening in diabetes. Two big factors. One, the vessels become weak and leaky. Because of the chronic inflammation caused by the sugar, you have weak and leaky vessels, number one, everywhere. Number two, you're in a hypercoagulable state. So the blood coagulates that little bit easier than what it normally does. So with these two things in mind, we need to work out the pathogenesis of damage to the eye. Now, blood vessels, unfortunately, are everywhere. Blood vessels are everywhere. So this disease, that what we're talking about in the eye, is actually happening everywhere. It's only in the eye that we can actually see it. So we can see and non-invasively see what is actually happening with the vessels in the eye without actually having to open up the person to see what his vessels are doing. So being able to recognize diabetic retinopathy is really important because it's a window to what's happening to the rest of the body. Now, because diabetes nails your blood vessels, all your blood vessels, everywhere, in your heart, in your liver, in your eye, in your toes, it's one of the most effective and efficient slow killers that there is. It's a slow and effective killer. If we do not manage it properly, everybody with diabetes has this uncomfortable, terrible disease that they've got to live with and all the complications that come along with it. So let's go through the pathogenesis and the stages of pathology in the retina. Right, because the vessels are weak and leaky, what now happens is extracellular fluid leaks out of the vessels, of those tiny vessels in the back of the eye. What does that do? That creates edema. There's a buildup of extracellular fluid outside of the vessels. What does the RPE do, the retinal pigment epithelium? It scavenges that leaked out extracellular fluid. It scavenges it away. So that's its job. It scavenges it away. As it scavenges it away, most of it gets taken away, except for the lipid molecules, because the lipid molecules are too big for it to scavenge away. So you get a bit of edema, and then you get the scavenging effect of the RPE. So what remains behind is the lipid. Now, lipid, as you know, is fat. It is well demarcated, is a yellowy color, and it's a rounded globular molecule sitting there, and that's what we call a hard exudate. It's a hard exudate because it has a well demarcated edge. It's basically lipid sitting there. Now, the problem with that, it doesn't say anything about where the leaking is taking place. It's only telling you where the scavenging is taking place. So there where the hard exudate is just tells you that there has been leakage and that there has been scavenging and that some of the lipid has remained behind and stays and is in the form of a hard exudate. So edema, hard exudate. What now happens when the vessel becomes more and more weak, more and more weak. It not only allows extracellular fluid out, it actually the bulges a little, and so weak that it makes a little aneurysm. And you get microaneurysms that form, microaneurysms, little bulges, little weak spots in the vessels. Now those weak spots obviously can burst easily. Now when they do burst, you get dot and blot hemorrhages. Dot and blot hemorrhages, meaning a blot hemorrhage is a more superficial hemorrhage in the retina, and a dot hemorrhage is a bit deeper. But they're both the same thing. It's little microaneurysms that have broken. The little microaneurysm breaks open, and a little bit of blood actually leaks out into the retina. So background diabetic retinopathy, or the first stage of diabetic retinopathy, is edema, scavenging away with the leaving back of hard exudates and dot and blot hemorrhages. Okay, so those are sort of the background changes, the early changes that happens in the retina. Then, because of the hypercoagulable state, you also get microemboli that form. And these get stuck in small vessels. And of course, there's ischemia distant to where the blockage is. That ischemia causes axoplasm to build up. Axoplasm builds up and is white and feathery in the form of cotton wool spots. So, very important, a cotton wool spot, a light, feathery, white, poorly demarcated exudate that sits there, is an indicator of ischemia. So in other words, you're in trouble here. Once you've got hard exudates and dot and blot hemorrhages, it means you're in the early stages. Once you have a cotton wool spot, you've crossed the border and you are now in an ischemic state. In other words, that retina is starting to shout for oxygen. It's screaming for oxygen. And the first thing that the body does is creates little shunt vessels between the arteries and the arteries and the vein capillaries. Tiny little shunt vessels, and that's called IRMA, intraretinal microangiopathy. Intraretinal, which means it never goes into the vitreous. It's just little shunt vessels that form there. So it's IRMA. So you get soft exudates, and IRMA are your early signs of ischemia. Now, when the body, anywhere in the body, when there is an ischemic system and it's shouting for oxygen, what does the body do? It secretes a hormone called VEGF, vascular endothelial growth factor. Vascular endothelial growth factor. Now, vascular endothelial growth factor stimulates the existing vessels to form new vessels. That's the only thing the body knows, how to handle ischemia. So VEGF gets secreted, it stimulates the vasculature to form new vessels. Now this is neovascularization. Now neovascularization takes place in two basic places and then eventually really badly further on. The two places are NVD and NVE. NVD means neovascularization at the disc, and NVE stands for new vascularization elsewhere. Right, so now you've got new vessels that are formed, but these vessels are not IRMA anymore. They're not intraretinal microangiopathy. They actually encroach into the vitreous, and that makes them vulnerable. So they can tear very easily and create vitreous hemorrhage. So you've got the stages now: edema, hard exudates, dot and blot hemorrhages. The first sign of ischemia is IRMA and some feathery cotton wool spots. The next stage that we get to is neovascularization. Neovascularization leads to bleeding into the vitreous. The bleeding into the vitreous, of course, takes massive amounts of vision away. What happens next is that vitreous hemorrhage starts organizing and starts creating a scar tissue. So if it's attached on this side to the retina and it's attached over here to the retina, and you know what happens to scar tissue, organized tissue, it actually contracts in time. All scars contract in time. So it contracts, and if it's attached, it sucks off the retina, and you get a tractional retinal detachment. Tractional retinal detachment. if the neovascularization fulminates, it can even crawl forward and be on the iris itself, and you have rubeosus iridis. In other words, you have new vessels growing on the iris, and you know that the edge of the iris, the base of the iris, is where the trabecular meshwork sits. So if that new vascularization crawls over the trabecular meshwork, you also get an increase in your pressure because there's less drainage, and that's called neovascular glaucoma. So there's the stages of diabetic retinopathy. If you know the pathogenesis, you just read it off. You don't have to remember what comes next, It's very simple. So let's just run through it again. You get weak and leaky vessels, weak and leaky vessels and in a hypercoagulative state. So the weak and leaky vessels create edema, scavenging away of the extracellular fluid, leaving behind the lipid in the form of hard exudates. The next step is where we have dot and blot hemorrhages from microaneurysms that have formed. So it's dot and blot hemorrhages. The next stage is where you get some ischemia, where you have cotton wool spots, where there's a buildup of axoplasm. Badass stage. There's your watershed ischemia. After the ischemia, it gets worse and worse, and you get VEGF that is secreted, new vessels that form. The new vessels bleed. The bleeding organizes, causes a tractional retinal detachment, and can even be as bad as climbing onto your iris and giving you neovascular glaucoma. So there you are, diabetes and the eye. So join me in the next video where we're going to talk about what can we do about all this. In other words, what are our modes of treatment in diabetic retinopathy? Join me there.